everyone, welcome to Positron Academy, and today's topic of discussion is on therapeutic radiopharmaceuticals. So let us have a brief overview of cancer therapy and how we can treat cancer. So cancer therapy can be broadly classified into two different divisions. We can either treat cancer through local intervention or we can treat cancer through systemic intervention. In local intervention, we have surgery and external beam radiation therapy, and in case of systemic intervention, we have chemotherapy and targeting therapy. So our today's topic will be more focused on this part, that is on targeting therapy by using radioisotope, how you go for targeting therapy. So this radiation therapy as a whole is the medical use of ionizing radiation, generally as a part of treating cancer to control the malignant cell. And we can broadly classify this radiation therapy into three main subdivisions, and these are external beam radiation therapy, brachytherapy, and systemic radioisotope therapy or uncelled source radiotherapy. So if you look at this example over here, that this external beam radiation therapy is very useful in treating cancer to a localized region. But if the cancer has now spread to multiple locations, so obviously by using this external beam radiation therapy, you cannot go for the curing. Then you have to go for other intervention like chemotherapy or targeting therapy for getting the remedy out of it. So our topic will be now focused on this part, that is systemic radioisotope therapy or unsealed source radiotherapy. So it all started by the introduction of P32 for the treatment of leukemia by Dougherty and Lawrence. And what this P32 is doing, it's a radiopharmaceutical. So this is delivering therapeutic dose of ionizing radiation and being used for the therapy of the leukemia. So this P32 is an example of a radiopharmaceutical, and we can classify radiopharmaceuticals into two main subdivisions, and these are as unconjugated radiopharmaceuticals and conjugated radiopharmaceuticals. So what do we mean by the term called as unconjugated radiopharmaceuticals? So these are those pharmaceuticals that target specific disease by virtue of the chemical, biological and physical affinity of the radioisotope itself. Example being iodine 131, which is an example of conjugated radiopharmaceutical, and this iodine 131 is being used for the treatment of hyperthyroidism. So this iodine 131 has a high affinity for the thyroid follicular cells, and it gains entry inside in the thyroid follicular cells by means of transporters, which we call as sodium iodide importer. And once this iodine 131 gains entry inside the thyroid follicular cells, it keep on emitting beta radiation, and this beta radiation keep on damaging cells by causing molecular lesions like double strand breakage, single strand breakage, and moreover the amount of unrepaired double strand breakage are very important for the radiotherapy part of view. And these are examples of some molecular radiotherapy when you are targeting at the molecular level to go for radiation therapy. Now in case of conjugated radiopharmaceuticals, this radionuclide or radiometal is being tagged to a ligand or a carrier molecule, and this ligand or the carrier molecule is very specific for a defined target. The target can be any protein, any receptor, and so on and so forth. For example, over here this carrier or this ligand is specific for this particular receptor or the particular target. So the carrier will bind to the target. So what we are doing over here, we are tagging the carrier with a radionuclide, which is over this one. So once we tag the carrier with the radionuclide, the compound that is being formed we call as a radiopharmaceutical, and this radiopharmaceutical is now directed to the target site, and based on the radionuclide will decide whether it can be used for therapy or it can be used for imaging point of view. For example, if this nuclide or radionuclide decays by means of alpha decay process or beta decay process, then we will be using it for therapy. And if this radionuclide decays by gamma decay process, we will be using it for imaging point of view. Fine. So these are examples of the conjugated radiopharmaceuticals. So it all started with the envisionment of Paul Ehrlich, who is an immunologist, scientist, Nobel laureate, and he postulated the notion that magic bullets could be developed to selectively target disease. And that is, these magic bullets are those molecules or those drugs or those therapeutics which have the ability to target disease cell and tissue. Fine. And he envisioned that antibodies could act as magic bullets because we know the fact that how specific antibodies are for a given antigen. And the first demonstration of this targeted radionuclide therapy was by the use of iodine 131 labeled polyclonal antibodies for the treatment of patients with melanoma. So these are the group of radiopharmaceuticals that are being used in targeted radionuclide therapy. So these are the therapy names like oral therapy, systemic therapy, local and regional therapies. And these are the name of different type of radiopharmaceuticals being used, their target and the clinical applications which it holds. For example, iodine 131 sodium iodide is being used in the treatment of hyperthyroidism and local and thyroid cancer, both local and metastatic. So this iodine 131 gains entry inside the thyroid follicular cells by means of an active transport process by means of sodium iodide imported. Fine. For systemic therapy, P32 sodium orthophosphate is being used for treatment of various type of blood related disorders. Example being polycythemia vera and chronic myelogenous leukemia. And this sodium chloride, metastron, and this group of pharmaceuticals are being used in palliative therapy of pain due to bone metastasis. And the target for this radiopharmaceutical are the hydroxyapatite crystal of the bone. And then these are group of drugs that are being used for radioimmunotherapy. And example Baxter, Zevalin. So these are group of radiopharmaceutical that are being used in the treatment of non-Hodgkin lymphoma. And these pharmaceutical or these radiopharmaceutical target the CD20 receptors which are overexpressed on the B lymphocytes in case of non-Hodgkin lymphoma. And this is a pharmaceutical over here, and it's a monoclonal antibody that is being bound to iodine 131. So, and this pharmaceutical, the target for this pharmaceutical is the intracellular DNA in necrotic tissue. And this pharmaceutical is being used in the treatment of advanced lung cancer, an example of an radioimmunotherapy because you are using an antibody for the same. And these are yttrium dotatate or dotatate or lutetium dotatate. So these are used in the treatment of neuroendocrine tumors. Fine. And we call it as a PRRT, peptide receptor radionuclide therapy. And the target for these group of pharmaceutical are the SSTR or somatostatin receptors, and these receptors are overexpressed in case of neuroendocrine tumors, and specifically the SSTR2, it is more expressed in the case of neuroendocrine tumors. Fine. The last is on this type is the iodine 131 MIBG, and it is also being used in the treatment of neuroendocrine tumors like pheochromocytoma. And last but not the least are the local and regional therapies like yttrium labeled glass microsphere, which are being used in a process called as radioembolization for the treatment of primary and secondary malignancies of the liver. And like TheraSphere and SIR spheres are being used for the same reason, for the treatment of primary and secondary malignancies of liver. So then we have P32 yttrium 90 and gold colloids, which are being used in the therapy of malignant effusions and or ascites, and we call that as an intracavitary therapy or peritoneum or pleura therapy. Fine. And the last one, yttrium 90 and ER colloids that are being used in the therapy of rheumatoid arthritis and the process which we call as radiation synovectomy. So the ideal radionuclides for therapy are those which have abundance of non-penetrating radiations like charged particles like alpha particle and beta particle. And secondly, those radionuclides must lack the penetrating radiations like gamma rays or X-ray. Now if you could recall from our previous lecture series, So we taught about that there is a daughter, there is a parent nucleate over here which decays to a daughter which is more stable by emitting some charged particles. It can be alpha particle, it can be beta particle, anything else. And this alpha particle has a defined amount of energy based on the Q value. For example, the Q value is 4 MeV, so we'll get an alpha particle which has an energy of 4 MeV. So the energy of the charged particle, it determines the amount of energy deposited in a given volume. So more the energy of the charged particle, more the amount of energy deposited in a given volume. And how do you express the amount of energy deposited? We express by a term called as linear energy transfer, and that is equal to L equal to d by dl, energy deposited per unit length of the matter. We call this linear energy transfer. And from our previous lecture series on clinical radiobiology, we have seen that higher the linear energy transfer, higher will be the relative biological effectiveness. And the penetrating radiations like gamma rays or X-ray, these are not essential for targeted radionuclide therapy, or a small amount or abundance within a appropriate energy like 100 to 400 kV, it may be useful for imaging studies to demonstrate the tumor localizations or altered biodistribution. For example, iodine 131. So this iodine 131, it decays by both beta decay and gamma decay process. Fine. So this beta decay process is being used for the treatment, for the therapeutic part, and this gamma will be used for the post therapy imaging to which demonstrates the tumor localization and the altered biodistribution. And beta particles, as we have already discussed, that beta particles, these are low lead particles and their RBE is unity, and you can see how low is it. It's 0.2 keV per micrometer. So these beta particles have low lead values. So if a given radiation has low LET, so the RBE will also be low, and if LET is higher, then RBE will be higher. If you have any doubt regarding these things, we can go and see my lecture series on clinical radiobiology. And these are the radionuclides that are being used in the preparation of therapeutic radiopharmaceuticals. And you can see that these are the radionuclides over here. These are their half time in days. These are the decay process, the maximum energy of the beta particles, mean energy, their range, and gamma emission if they have. So not all radionuclides will decay by both process, like both beta and gamma. And we can see there's a lot of nuclides which are decaying by means of the beta process, by the beta decay process. Fine. And there are some radionuclides which decay by both beta and gamma decay process. Fine. Example being iodine 131, which decays by both beta and gamma, and the beta maximum energy is 0.61 and the gamma emission energy is 364 kilo electron volt. I guess you must be familiar with this one. What is the beta maximum? So if you go and see the spectrum of the beta radiation, so that's the E beta max. Fine. So these are the radionuclides, their T half and the decay process over here. One thing that you can notice over here is the range of the beta particles. The range of the beta particles are in millimeter range. So these beta particles have higher range as compared to the alpha particles. If you go and see the alpha emitting radionuclides and see their range are in microns. Fine. So beta particles has higher range than alpha particles. Fine. And we can see over here that iodine 135 over here, which has an half time of 60.3 days, and it decays by electron capture, and it has also have an OG electron or low energy electron having energy of 0.40 kilo electron volt. Fine. So one important factor which is very important is we call as the effective half time of a given radiopharmaceutical. It's very important because the time course of irradiation of a target is very important. For example, that's the tumor over here. So the time of irradiation of the tumor by the pharmaceutical, it depends on two different factors. One is we call as the physical half-life, and one is we call as biological half-life. So the physical half-life of the therapeutic radionuclides is very important, since the time course of irradiation of a target is related to both the physical half-life and the biological turnover or the biological half-life of the radiopharmaceutical. So the time course of irradiation of a target is related by both the physical half-life and the biological half-life, which together we call as effective half-life of a given radiopharmaceutical. So the next part of discussion is on crossfire effect and bystander effect. So what are these crossfire effect and bystander effect? So it's not always a compulsion that a given target will have equal distributions of receptors. For example, we have a tumor over here. So it's not a compulsion that it will have equal density of receptors all over the tumor surface in a homogeneous manner. And if it has a homogeneous distribution of receptors over its surface, then the amount of nuclides or pharmaceuticals that will bind over it will be homogeneous, and the course of irradiation will be homogeneous. But assume a situation in which the distribution of the pharmaceutical is not uniform, rather it's non-uniform in nature. So suppose this part of the tumor has higher density of pharmaceutical, higher density of receptor over here. This part have lower density of the receptors. Fine. So pharmaceuticals or radiopharmaceuticals will bind more over here. So the irradiation of this area will be higher compared to this area. So it means that this area will be spared more than this area, but that's not the case. Fine. There is significant destruction also over here. But if pharmaceuticals or radiopharmaceuticals are not present over here in sufficient quantity, then how this area goes through a sufficient reduction in cell survival? The answer is because of two different effects, which we call as the crossfire effect and the bystander effect. And because of these two effects, there is significant amount of cell killing. So what actually happens in case of crossfire effect? So when a radiopharmaceutical has a non-uniform distribution within the tumor, for example, you can see over here that this radiopharmaceutical has bound to this cell but not to these cells. But as because this particular radionuclide has high energy beta particles, and these deposit energy in multiple cells, and as a result of which those cells which do not have these binding site for the radionuclide are also getting irradiated. So what actually is happening? So this particular radiopharmaceutical is cross-firing to multiple cells and leading to their irradiation and also leading to cell death. And one more factor is we call as the bystander effect. So it's not a compulsion that all cells will be irradiated in a given tumor mass. For example, in case of the external beam radiation therapy, we are irradiating the whole tumor with radiation. So we are almost all cells are getting irradiation. Fine. But in case of radioisotope therapy, not all cells get the irradiation. So there are some amount of non-irradiated cell. So if a cell is not irradiated, so that won't die, but still we see sufficient amount of cell death to the non-irradiated cells, and these are because of a signal that is being emitted from the irradiated cells. For example, these cells is irradiated by the radiopharmaceuticals, and these are the crossfire radiation. So this cell has crossfire to these cells, and these two cells are now irradiated. Fine. Now this irradiated cell keep on secreting some signal which we call as bystander signal, and because of the signals it lead to the cell death of the nearby cells. So in together both crossfire effect and bystander effect are resulting in cell killing and resulting in effective therapeutic response. So these two effects are very important for nuclear medicine part of view, the crossfire effect and the bystander effect.